Sí. No, tiene letras.
Te escribo, gracias.
Nada. This one is the conflict of interest to share your slides. Right? Okay. Good afternoon. Hello, everyone. Okay, so I'm going to go over first. Good afternoon. I was running from a meeting, so I was like, oh my God. Anyway, I think translators have everything, and we are ready. So my idea for today is to try to share a practical guide to try to organize what we are seeing with some of our patients and how to organize the type of work we can be doing, right? This is not meant to be A, B, C. I mean, we cannot do that with dissociative disorders. We really need to learn to be curious, try to understand, work with the conflict, and it really gets to a point where it's very automatic. But in the beginning, it might be more complicated. For me, it was more complicated. I think it was partly due to missing a lot of experience, not understanding many things I was seeing, and yes, and maybe some other issues that I was not identifying. So what I tried to do is when I started to present and showing some videos, some cases, I was getting questions from colleagues saying it seems like you have a clear idea of what you're looking for. Could you explain that? And for me, that was a really difficult question because how do you explain that in a couple of minutes, right? So this is what I try to do. I try to think a little bit of what am I doing, how am I doing it, to try to share something that I hope can be practical. Okay, I will be showing some videos, and I always say, please, information is confidential, right? No recording, no pictures of patients in the background. And I always say, I know in some places colleagues show role plays. These are people, real people with real suffering, with complex histories that sometimes their family doesn't even know. And it would be really horrible for them to, be not respected in that way. Anyway, so what we are going to see today is based on this book, on the work with voices and dissociative parts. And sometimes colleagues were thinking, why are you mentioning voices? Many people might not be interested in this. And well, I am. I think it's important, and I think that many of our patients hear voices, and many people hear voices in different ways. They don't always interfere. There's a lot of research about hearing voices in population with no diagnosis too. They don't have the complications that the patients we see who hear voices and are very frightened by their inner experience have. Right? So it has we are going to go over a part of this whole book that turned into something really big in the end when it was meant to be simpler. Okay, so basically here we have some of the structure, and just to get an idea of what we are talking about is an introduction about some concepts, theoretical models, and some clinical interventions or procedures that can be useful to understand the practical part, right? Then It's organizing how to set up the therapeutic work and how to organize, how to structure the sessions. Then there's some work on how to develop the adult self. A specific chapter on working with exploring the system and understanding the conflict, and I might go over some of those questions today. And then some specific issues with some of the challenging parts. So I really try to make it specific. Some things are shared or similar, but they also have their own particular differences. So this is why it is organized this way. So the first idea is how to begin the work, right? And in general, this is something that might be familiar for many of you, or when I go over this, you might think, oh, I do a lot of this. Okay, so that's perfect, right? I think many of us get to the same place after practice and with different names okay. So in general, what I was thinking, right, when we are trying to come up with a structure of how we are going to organize the work, the first thing is our alliance, of course, and safety in the setting, and the person feels confident enough that they can speak about what happens to them, right? But initially, we want to be exploring the voices and parts, the associative parts. We can do this in many ways. We can explore the content if they are ready to talk about that. This might be easier with some clients and not so easy with others. We can explore the tone of what they're hearing, if it's a voice. We can try to get an idea of what the message that is there, although most of the time it's going to be, if there's a lot of conflict, it's going to be filtered through a very negative way of looking at the message because the patient is afraid and what they experience is something they want to get rid of. So they will say something really negative about the message, or the message is very horrible and we need to help other parts to communicate differently. So the message underneath whatever is horrible can come up, right? So we can try to explore the moment of onset that's related to getting an idea of when parts are more active or show up or get triggered. So it's related to what I go over in exploring triggers. Sometimes this could be triggering, so just keep in mind that we need to adapt to each person and their capacity in that moment, okay? So some people can respond very well to all of this, and some people we need to slow it down. I was trying to show a video with a young girl in the workshop I presented with Kathy and Suzette, where I really had to slow down in different moments so she could continue, right? And many of the things I could not even think about exploring, okay? So it really depends when. So we want to be encouraging our patients to listen to voices and pay more attention to the parts, right? And this is complicated because, okay, so I'll go over this a little bit with let me just go over in general and then go over each one. We want to explore triggers. We want to get a sense of the trauma-related phobias, right? This is from structural dissociation theory. So when you see dissociative phobias, it's really about that, about trauma-related phobias, especially between parts. We want to assess the degree of differentiation that is quite an issue, and time orientation in patient and parts. We want to be exploring and validating the function of the dissociative part or the voice, identifying and validating any resource available in the system in any of the parts and any of the voices, feelings, needs. We want to be very validating of everything inside. And we want to especially be modeling a different way of responding to everything that happens with them, right? So another thing that I think is interesting in different moments of therapy is to try to find out what missing pieces we might be there, and I will talk a little bit about this. And from the beginning, although it's in step 10, we want to be reaching some type of agreement and developing cooperation and teamwork. Okay. So, like I was saying before, let me go over this a little bit, and then we talk about the different sections that I was mentioning before. The first idea, sometimes we get a little bit too obsessed with mapping the system. That's not what I'm trying to point out here. The idea is not to go crazy with how many parts are there from the beginning and try to identify every single one. That's not possible in many of the cases. Some of them can't even accept the possibility that those parts belong to them, okay? So the idea is for us to have an idea of what we are working with. How is this system organized? How is this person responding inside, right? So then we can get an idea and help our patients make more sense of what happens with them, okay? So the idea here is not to force anything or get into too many details in the more complex cases. It's an idea, okay? I will try to go over this. So if the patients, it's written in English, this book, not in Spanish. So the book I've been working a lot outside. I know in Europe we use a lot of patient. In the US, we tend to use client. So you hear me here talk about patients or clients, but it's the same thing. So if the patient indicates hearing voices, that's when we can explore the tone, right? What is a tone? Right? What is it saying? What do you think it's trying to communicate, right? And the idea is to get to the underlying issues behind that, which is not easy for patients, especially in the beginning. Sometimes, often, it's a repetitive message that apparently doesn't make any sense, right? Or a clear message geared at achieving a certain goal, right? Of course, this is something that is not very clear initially because we sometimes also get confused. Sometimes it might be a little bit difficult when somebody hears a voice that keeps telling them, throw yourself out of the window, kill yourself, or hurt that person, that there might be a different intention underneath that message, right? So sometimes we can even become confused, and sometimes what I hear in supervisions is how some colleagues kind of, it's easier to work with the nicer parts, and some colleagues talked about this, right? We need to be more curious initially with the ones that are more challenging because those are the ones that are protecting and can really get in the way of the work. Okay, so in the beginning it might not be so clear, but eventually we will get there. So we can also introduce questions, and many of you are familiar with this, right? This is very basic stuff about how old does the voice sound, or how old does this part seem, right? Sometimes, like in the video I was showing in the pre-conference workshop, when I asked that, the girl quickly said, very young, and I say, how old? 6. So sometimes it's very specific, it's very clear, and sometimes they really do not know. Sometimes the phobia gets in the way, and that's why they can't really tell us. Or sometimes younger parts present in a really aggressive way that seems older. So it can be due to many reasons. So yes, the idea is to kind of get this what are we seeing? How is this internal representation? Then we can also explore the moment of onset and when voices appear or show up, and this is related to the triggers. This is what we are trying to find out. That doesn't mean we are trying to go into the detail of traumatic memories, because that might be way too triggering in the beginning, okay? But it's trying to find out the function and what is getting triggered. Step 2 is a challenging one. And this is something that I had to learn to kind of be more clear about it with some of the patients that hear voices, because sometimes they understand in a very literal way, and sometimes they get confused about what we're trying to achieve here. When I suggest my patients to try to be more curious and pay attention or listen to the voices or parts, that doesn't mean that they have to act on it. Okay, this is important because often they get confused. You know, something like one of my patients, he did a severe self-harming behavior, and when I asked him what happened, he said, well, you told me to listen to the voice, and that's what it was saying. So that's not the idea. The idea is to try to be more curious, but also make sure you introduce the idea that, you know, I want to help you understand what's happening, but that doesn't mean that you that listening does not mean you have to do what they say. Sometimes they are learning how to communicate something important, and how they communicate is not adapted to the present situation, right? So this is something that is actually very important, okay? So we want our patients to be more curious and interested in their inner world, which is a challenging issue, unless there's no phobia towards some of the parts, okay? And like I was trying to introduce, promoting curiosity might be easy with some parts that our patients can maybe not accept, but tolerate or understand that they help in some way, but it will become more complicated with the challenging parts. So this is why we, from the beginning, want to get the idea across that the part or the voices are actually trying to help, right? And often we get a very negative response to this. I'm pretty sure you have found this in your clinical practice, right? We say, well, I think maybe this part is trying to help, and they look at us like, oh, like we are taking sides with the part that they are so afraid of. So the idea is that I understand you don't see it this way for now. It has to be very scary to listen to a voice that keeps telling you that you have to do this, right? Or it has to be very frightening to have a part that takes over in situations where you want to be there, and that it makes it more complicated for you right now. But I'm guessing it's because it doesn't know how to do it differently, right? So it's about repetition that they might eventually understand this little by little. And this is where our knowledge about the patient and the system is important. When I talk about exploring triggers, right, this is about finding out the function. If we explore trigger, we understand the function of the part better. It's very basic, I know, but this is something that it's important that is clear for us. So the best way to explore triggers is not really going into trauma history, right? It's not about that. It's really try to explore what was happening when the voice started getting louder. What was happening when this part showed up? Do you remember? Sometimes they say, I don't remember. I just know I cut myself. Okay, let's try to go back a little before you did that, right? What was the situation? And eventually we can get to a trigger without getting into all the details of whatever is too much for the system. Okay, now I have Spanish in here, but it's exploring triggers. And one of the things that if you were in the pre-conference workshop, you saw me do this with a young girl, introducing general psychoeducation about things that might make sense, not interpreting, which is very different, okay? So sometimes we can get the message across that, you know, sometimes parts, voices, things in us, whatever language they use, right, show up when one is not feeling good or when one does not know how to respond to something, you know? So we will use a language that is adapted to the patient that we are seeing, right? And most of the time they can begin to understand the idea, right? They might not like it and they might not agree with it, but it is going to make sense for the other parts, which often get calmer, and that's how the patient can continue the interview. This is what we were seeing in that video, right? By talking in general to the parts, the other parts were not saying anything, and she could be more focused on what I was asking, right? If I'm saying something that is triggering the parts or the voices, it gets too loud inside or too frightening, and they can't be with us, right? Okay, sometimes when the triggers, it's related to something that reminds them of the past, right? Especially parts that are stuck in trauma time. So one of the things that we need to keep in mind is, and this is it's very basic, but I think we forget often. I think we often forget that when parts are stuck in trauma time, the system is responding as it was responding back then. It's not adapted to the present situation. And sometimes we think we have worked with some parts, but there are others we are not aware of that are still stuck there, right? And that's why difficulties keep showing up, okay? Sometimes there's some exceptions. Most of the time when I ask, so when does the voice get louder? Can you tell me about that? Always. Well, always? Can you try to think last time, right? So we help them. Oh no, yeah, well, it's when I feel bad. Or sometimes they know, oh, it's when I feel bad, it's when I feel frightened, it's when I can't take it any longer. But sometimes we have some exceptions, especially in cases of sadistic abuse, where they get triggered when they feel good. And this is a big issue in therapy, because therapy is about making people feel better, right? So if they get triggered when they feel good, this is something that is going to interfere in different ways. Okay, so sometimes this is where our knowledge about the case is important, because we can start linking it to what they learned and how the present is safer, right? So you get triggered when you feel good about something. And this is kind of what you learned, isn't it? I know this is difficult for you, but what happened when you felt good, right? If I remember correctly, you told me you were punished. Yes, so it seems like something in you gets frightened when you feel good, right? So we are linking what we are seeing with something they need to understand, and this sometimes calms other parts. Sometimes we will see another part that shows up and doesn't like what we are doing. So we need to be curious about that and say, hey, it's important. So what is it that I'm saying that is bothering this part? And we get more and more access to understanding how the system is organized, okay? And what we need to work with to reduce this conflict. So we want to be exploring in different moments, right? Trauma-related phobias, like I was saying before, right? And if we are trained in EMDR or other trauma approaches where we work with processing pieces of information, this is a good opportunity where we can actually desensitize or process a little bit of the experience, right? And sometimes what happens is that the conflict is reduced enough to continue exploration. Or something becomes more clear because maybe a part is trying to communicate it and another one is getting in the way and the patient is frightened. So if we work with the phobia, right, of the patient in front of what's happening inside and it gets reduced a little bit, they can kind of see more clear or listen without so much noise. Okay, so phobias among parts are one of the main obstacles that prevent the natural flow of treatment. And this is why we need to be checking how the different parts and the adult self, if we are talking about this concept that I will explain a little bit, feel towards each other, okay? This doesn't mean that we need to get lost in part language, right? It doesn't mean, like, if we are exploring a phobia, it doesn't mean that we have to say, okay, so how does the little girl feel with what I say? And the teenager, and the dark shadow, and the wolf, and that's not helping. That is going to divide more, okay? So it's really about, so what happens inside when I say this? What do you notice inside when I suggest that we work on this or that we explore this other thing, right? In a general way, we are more inclusive, and we avoid working with parts that are not really needing intervention in that moment. So we are integrating, not separating, yeah? Okay, so, and yeah, like I was saying before, for therapists trained in EMDR, if we think about the rationale of the adaptive information processing model, when emotions are dysfunctional, such as when one part is frightened of another part or feels disgusted by it, right? I can't stand it, I hate her, I'm so ashamed, right? This is something that can be very useful to actually target. But we need to be familiar with the approach to do this type of intervention. So if you're not familiar, I would never recommend that you try this out, because it can be it can invite negative material like this very quickly. Okay. So when we explore trauma-related phobias, this is always a good way to organize our work, right? Because depending on the information that we obtain on the phobia between parts, we can be able to identify whether it's necessary to start maybe processing them before we continue, or maybe do some work with this part that can allow us to continue this work with the other part. One of the things that often we see is how younger parts are closely related to perpetrator parts, right? Perpetrator imitating parts. right? So sometimes we feel kind of it's a good idea to work with a younger part, but then another part thinks we're going too fast, and then everything turns into a nightmare. So we need to be really, really checking inside to make sure that everything is going okay. Another thing that I thought was important to keep in mind, although it's very basic, but like I said, I think sometimes we forget, is we need to assess the degree of differentiation and time orientation in client and parts. And this is something that often goes unnoticed, right? And sometimes what happens with many of the patients we treat is that distinguishing between internal and external elements is not easy at all. Okay, it really gets confusing. Sometimes problems with differentiation are related to boundaries, right? Not knowing what they're supposed to tolerate from others, right? Or how far they can go with others. It might also include having difficulties separating what others think and feel from how they think I feel, right? Sometimes this is too confused. Or have difficulties distinguishing the message they have internalized from the reality, right? So if somebody heard over and over that there's a disgusting piece of whatever, right? It is very complicated to have a different view of the self, right? And sometimes this is kind of a reality because this is what I know and it's a fact, right? This is how it's experienced. So a crucial issue with differentiation is related to separating what is happening now from what was happening then. So this is one of the crucial aspects that I was talking about, right? So we need to keep in mind that some of those parts are still stuck in trauma time. The voices, same thing. Frequently, they have no idea danger is over. That's why they just repeat whatever they had to do back then. And they continue as responding as if the danger was still happening. Okay. So just from time to time, we can check how present they are and just make sure. So does this part know that we are here and this is not happening? Very often they have no idea, and some parts even get upset about this, right? They don't really like it when we bring this up because their role is to really protect from realizing relevant aspects too. Okay. So it is important to keep them oriented to the safety of the present moment when they lose dual attention and when we see that this is happening. And like I was saying, it is not going to be an easy task. I think sometimes we oversimplify this. We think that just by saying, hey, you're here, it's 2019, you're in my therapy office, and everything is fine now. And this doesn't work. And sometimes, we get, when I'm going over some cases, I try that. Well, let's see how you tried it out. Let's try to be curious because sometimes, we make it a little bit too simple, and it's really about checking inside what happens as I say that. And some parts might tolerate it, and others might even get angry. One of my patients was getting angry, or was getting really overwhelmed because a part was saying, how would she know that, right? And this is what was really getting in the way. Anyway. So we also want to be exploring and validating the function of the part, right? So when we explore triggers, we try to get an idea of the function, and then we validate it, right? Even if the patient does not agree to it or cannot understand it yet. So the idea is parts are there for a reason, voices are there for a reason, and we really want to understand what they're trying to achieve. This is basic in treatment. This is basic in how we organize the work. Okay, if we find out what they're trying to achieve, we can find out other ways of achieving it that are not causing dangerous complications for our patients or the people they relate with. Okay, so yes, so sometimes, like I was saying before, we will introduce messages that are very basic, right? We're used to doing this. Like, I understand this is very difficult, but I'm pretty sure that there's a good reason for this, okay? So let's just bear with me. Let's try to understand. Let's try to be a little bit more curious, right? And we also have to remember that in some cases, parts were created to perform a certain role. And this is what they had to do, right? For instance, in one of my patients, she developed different parts that were in charge of protecting her, right? So she was severely abused, sadistically abused for many, many years. And she had different parts that were really making sure that she did not have needs, that she did not complain, that she did not enjoy that. So, and other parts have roles about really keeping the alert really activated. And this is something that we need to understand, that those parts help them survive. This is basic, but I think we forget. And when we are intervening with some of the challenging cases. Okay, so the idea, and this is, we have many bright minds that have taught us about this, right? And how can we give these parts a more adaptive role in the present moment? This is mainly the idea, right? And what was adaptive in a given situation in the past is not necessarily adaptive anymore. And this is something that we need to explain and introduce, right? And often what happens is that when we get to see the patient, it's not only not adaptive anymore. I mean, the intent is to be adaptive, but it's causing more problems and more conflict inside, okay? And this is why patients might initially have a really difficult time believing that parts are trying to help, okay? Especially the hostile ones, because they make them feel really horrible, right? So how do we do this, right? So if we respectfully ask questions about the part and model a different ways of responding, a healthy curiosity, not focus on traumatizing events, which is one of the issues that really gets things out of the window of tolerance, patients can become curious themselves, just little by little. It's not going to be in the first session. If this happens really quick, we are not dealing with a really complicated case that needs a lot of work with this, right? But often this is very challenging, okay? So, yeah, how can these parts help this person in the present moment, right? And like I was saying before, sometimes patients get upset about the voices and the actions of parts, and the internal conflict and the phobias do not allow them to appreciate how important these parts have been for survival, right? I remember the first time I introduced the possibility that in one of my patients, she had a really aggressive part that protected her since she was 3. Right? And she was so frightened because the part was really aggressive. She would take over and hurt others, right? When she was not setting boundaries. And then my patient would become terrified of what was happening because she felt she was going crazy and had no control. And she really was saying things like, there's a phantom, that I'm possessed, somebody's trying to kill me, she's trying to steal my body. And it sounded really psychotic for some colleagues that actually diagnosed her as psychotic, and she was medicated and everything just got worse. Okay, so the first time I introduced the possibility that this part was trying to help, right, in a general way, like I was doing in the video I showed in the pre-conference, she gets really, she starts getting like really, red, and she's saying, I don't know, she's like acting weird, and I say, what just happened when I said that? And she says, well, I just heard you with a little bit of interference. And I say, how's that? Well, she's saying she gets it, right? So in the first session, I didn't get a very good alliance with the patient, but I got a good enough alliance, or at least some curiosity with the most challenging part, right? And that helped the patient to be a little bit more motivated to try to find out how this type of work could help. Okay, so yes, validation is very important in helping our patients to understand that. So that's basic, and another thing that is very basic, and we need to make sure to introduce it, is first we want to, every single person we see has value, resources, things they're good at. They might not see it, they might not appreciate it, they might not even think that this is a possibility, but it's important that we also not just try to find out what's going on, what happened to this person, which is very triggering in the beginning, but how did this person survive, right? What are they good at? and how can we use this. And some parts have good resources that other parts don't have, and we can use these resources so they can use them too. Okay, so we also want to be identifying whenever we pick up anything that is important. Make sure you stop there and say, you know, this is really important. Do you realize what you just said or what this part just brought up? Okay, so we want to be validating what's good, what's working in the system, and any feeling. I understand you don't like this, but this is important, and she has the right to be mad. Yeah, and it's okay. You know, I'm pretty sure she has very good reasons not to trust me. I'm okay with that. Can you be okay with that? Right? So this is also about modeling, right? This is another one of my patients with a part that would not trust me. I'm not trying to, you know, trust has to be gained. We can't just be trusted because we're therapists. And when that goes too quickly, I think this is a part of the problem that some patients have, especially borderlines, when they trust us way too quickly. Okay. Also needs. Many of our patients were really humiliated or punished by expressing needs, right? So they learn to just ignore them, push them away, and even think they don't have them, right? So it's important to introduce psychoeducation about how every single human being in the planet has needs and how it's important, right? And how we need to be identifying them, paying attention, and trying to have them met. Okay. So another thing that is related to this step is that sometimes we have patients that have very opposing needs and feelings, and you know what a part might need to reach out and maybe be accepted is something that another part is trying to avoid at any cost, right? So this is also about understanding that this is how the system is organized, and that's why we want to be reducing this conflict and finding a way to meet the different needs, right, in an integrative way. Okay. It can help all the different voices and parts to feel heard. And somebody was saying that the other day when I was asking, why do you think she's calmer? With one of my patients, she started like really, really frightened in the interview. And one of you said, because the voices feel heard. Okay, yeah, and this is very important. When they feel heard, understood, trust is not really there, but we get curiosity, right? And this is an important, a huge part of the work. Okay, and is usually a missing experience for many of the patients we see. Okay, did I go back? Yeah, okay. So the key in this type of validation is to make sure that we accept every single part and every single emotion that they verbalize, even the ones that might seem not adequate in that moment. Just say, okay, I understand this is very frightening, right? When you have a part that wants to break somebody's head open, I understand this is very frightening. Can we just accept that this part is angry and probably has very good reasons to be angry? Yeah, that's not how it's going to solve the issue, right? But so we are validating and then trying to find another way of expressing whatever anger, whatever emotions are difficult in there. Okay. So by just being consistent in this way of being in front of our patients, all the parts learn to eventually get this other way of functioning, okay? And to internalize a new way of responding to their feelings and needs, they need to see this. Many of our patients were just not treated like human beings. They have no models. They have no good models to really learn basic things from. So having a consistent therapist that is not trying to rescue them, but is trying to help them as a team in a cooperative way, how to understand and make the best out of this is a big difference, okay? So when we are modeling in a consistent way, eventually it ends up sinking in to all the different parts. Okay, so we want to be exploring the needs in different moments. So we might not be able to do this initially, but when we get enough curiosity or we reduce the conflict a little bit or enough, we can start introducing, so what do you think it might need? I have no idea, right? Like one of my patients was saying, oh, I think she needs to fucking relax. It's like, okay, so can we explore that a little bit more? So you think she needs to relax? What is telling you that? And little by little, we get to a less complicated message. Okay, so yes, we want to be identifying the resources that are working and the ones that need to develop. So we need to be doing a little bit of both, right? And the ones that exist, because often our patients do not value what they do, even if they're good at some of those. They have some capacities, okay? Let me see. Okay, we cover this. So like I was saying before, identifying and validating resources, feelings, and needs might be quite easy, right? Straightforward with some parts, but very complicated and challenging with other parts when the phobia is very high, okay? And what happens is, this is related to mental efficiency, right? Which is a concept that probably most of you are familiar with, right? Our patients spend so much energy dealing with the conflict that they have very little energy left to function in daily life, okay? So this is why we want them to have a little bit more energy available, okay? And then another thing we can try to do is, maybe get a sense of what part or what voice can help in what, right? One voice might have the capacity to help defend the system, another to identify possible danger, and a third to be playful and enjoy life, right? So we make the best out of, this can help in this way, and this can help me in this way. And maybe this is not adequate in this situation, but it's very adequate in this other situation, right? So we are already introducing a lot of psychoeducation there that is important, okay? And introducing the idea of cooperation and teamwork, which is essential in these cases, okay? And by doing all of this, we are leading up to a more integrative way of thinking, relating, and being, okay? So if you're trained in EMDR therapy, resources can also be installed when needed, and any relevant insight that comes up from an intervention we did, something that really generates a change, like a realization in the system, and there's no conflict around it. Sometimes I get asked, why didn't you try to reinforce that? The conflict was not lowered enough. There's too much, if the conflict is there, we are only going to invite negative material. But if something led to a realization that is shared by the system, we can actually reinforce these relevant insights and realizations. So all of this is done through exploring, right, modeling, and practicing these alternative ways of responding, right? And what's really important is that our patients realize that they have options now. Often this is another basic thing that we forget to bring up, right? Many patients really cannot realize that the situation is different, and now they have other options that were not available, and other parts do not realize this either. That's why they keep repeating what was helpful. Okay. Okay, so then we want to be introducing how to think of different ways of responding. This is some basic resourcing work, and sometimes suggest more useful or adaptive ways in which the voice can really help. Right, for instance, with one of my patients, he was locked in his house for 2 years. This was an artist. He could not draw. He could not do anything because he had a critical voice that was always putting down everything he did. So it got to a point where initially the voice was trying to protect him from being criticized, but it got to a point where he ended up locked in his house without being able to function, right? So by exploring what the voice was trying to achieve, he could understand that the voice was trying to protect him from humiliation and being hurt. And then we went to the voice and said, okay, so does this voice, and how does that make you feel? I asked the patient. Bad? Does the voice know that you actually feel really bad? So we did a little bit of work around that, and the patient could say, I understand that, having a critical something there to alert me is good, but it's way too intense and it just paralyzes me. Okay, so what can we do? And of course, this voice was too critical to give any positive message. The client said something like, how about maybe he could say, hey, you can do it. And I said, well, maybe we're not there yet, right? That would be really good, right? But if he's trying to protect you and he's doing it in the way he has learned to do, how about we try it we try to ask him to not say anything this week, right? And then I will ask, and when we meet again, he can say whatever he thinks about what you are doing. So we reached an agreement that was okay with this part, and he eventually was able to draw in not such a long time. Okay. And then I made sure that I checked with the voice, and he was still very critical, but differently. Okay. So yeah, most of the time when we explore, sometimes when we ask our patients and say, so do you think the voice or the part knows how much this bothers you? So the patient will say something like, of course, that's why it does it, right? So sometimes we can say, okay, I understand that this is how you feel, right? But can you check inside? Can you check with this part and ask if it's really aware that this hurts you so much? And I remember one of my patients when she was very surprised because the part said, I don't do it to scare her. Okay, so yes, this is kind of like this therapy group inside one person. Okay. Yeah. Sometimes the simple fact of checking, so what does this voice think about this? It's very different. It's something that it already brings a positive effect because they're used to, especially voices, and when colleagues are still thinking of, oh, this is something that the patient needs to ignore, not pay attention, and take medication to make it go away, that really is not helping and it's making things worse, right? So when they find a different way of, a different attitude about that and a therapist that's curious, we already start seeing changes. Sometimes not huge, but it's significant in the beginning. Okay, they're not used to anybody checking in with them, and this is important. Okay, so and then another thing that is very important. Sometimes with some of the voices, we can't really expect them to. They are so rooted, it is so automatic, and it's so repetitive that we can't really go there. Right? We don't get any answer back. They don't communicate. They don't seem to collaborate. Right? So sometimes we just need to work through the patient and say, okay, well, let's think about this. So the voice just keeps repeating this and this and this, right? It doesn't seem to have too much of a repertoire, does it? Of course, we can't say this in a humiliating way for a part because they won't like it. But if we say, it doesn't seem like it learned different ways, but I'm pretty sure it can learn if we can help it. Right? That's very different, okay? And sometimes, so we start working with the patient so they learn to respond differently. And they get really surprised that sometimes when they respond differently, then they start seeing changes in the rest of the parts. I remember one of my patients, and some of you know him, he would just get a voice that was always insulting and telling him to hurt himself or hurt others, right? Well, he had different voices that were all aggressive. And in the beginning, it was impossible with one of the voices. It was just repetitive, kept saying the same negative messages to get anywhere, right? So we started just working with how he responded to each one of those sentences, right? So just breaking it down so much that he could respond differently. Okay, so the part says, you are a loser, kill yourself. What he responded to that? And the answer was, I'm not a loser, you are. And this was a fight. I say, okay, well, that's not really helping either. So why are you not a loser? So let's try to think of something else. So eventually it's also working with the capacity to, dialogue in a different way. And this was a huge change for the system because once the patient was able to verbalize something that was not the same type of conflict back and forth, right, almost like two little kids fighting, the voice shut up. It didn't know what to say, right? And this is one of those moments I love in therapy. Like I remember working with another patient where he had a part that had this red eyes. It looked like a demon, and it had like Freddy Krueger hands, right? And the part was trying to cut them in half all the time and divide them, and it was very frightening. right? So I was working with this guy, and I was saying, so what's going on with this part? His first response initially is like, oh my God, what is that? I see a really like a demon girl in there. Okay, so by saying, so what do you think is going on with this part? Oh, it's very angry. Okay, and how old does it seem? Little. I don't know, it doesn't respond, it's not like the others. So what would you do with a young girl that is so angry? So he's like, all right, give me some time. So he kind of just goes in and say, take your time, be angry, just let it out. It was really nice. And then the part just started breaking everything, scratching everything, trying to cut them up. And he was just like looking at it with acceptance, right? Of course, we had worked with other parts before that. If not, it would be impossible. And it got to a point where the part calmed down and was like kind of exhausted, just sat down and was like this. I say, so what's happening now? I don't know. It's just sitting there like, and what do I do now? And that's because the patient was not responding, trying to make it go away, right? Which is part of what was taking place before that. Anyway, so these are basic but important things in the work. Okay, like I was saying before, most of the time clients would say things like, yes, of course it knows, and it wants me to suffer. And this is what it wants. And we can have some sadistic parts, and we need to work with those to try to understand, right? Where was that learned? How is that helping now? And it's more challenging, it takes more time, but eventually it's kind of the same type of work, okay? Okay, so I already covered this. So yeah, sometimes we do a lot of psychoeducation, and we have excellent material on psychoeducation that is very helpful, but this is not enough, okay? So sometimes the best way for the new attitude to really sink in is through what I was saying before, through just, having a different response, a consistent response every time that the conflict shows up. I really like this sentence, right? And this is a sentence from Einstein. And it says, example isn't another way to teach, is the only way to teach, right? And I think this is important in therapy, right? If we get frustrated, we get, with parts, we lose patience, we are kind of repeating what they experienced before, and that's not really going to help us. So this is why just staying curious is actually one of the main resources we can have as a therapist. Okay, and remember that many of our patients did not have healthy models to learn from. They had really horrible models sometimes not good enough, but other times really horrible. And many of the basic elements that we learn as we grow up, right? Boundaries, basic emotions, needs, they're not developed. So we have an adult that has some capacities, but many of the basic capacities are not developed, and we need to help them develop that, okay? And then, when I refer to step 9 and identifying and exploring missing pieces, I'm referring to something that is obvious that is not showing up, something that is missing, okay? Sometimes it might be an emotion, right? The typical situation is the patient that never gets angry. Then they explode in a very out of control way, right? But they hate anger, it's never there. So sometimes when we have a good enough alliance and we know the system well enough, we can try to explore that and say, so wait, how about anger? What's going on with that? Do you get angry, right? And it's really about bringing in these other pieces or the other parts that are kind of put away because it's intolerable to think that that belongs to me, okay? Yeah. So another thing that is important is that when something doesn't fit, just point it out, okay? This doesn't mean that we have to, I'm not saying point out everything that we see. I mean, sometimes when we get trained in body approaches, I think we start getting too focused on pointing too many things out, and this is actually very triggering for dissociative disorders. So, but when something doesn't fit, right, and we are exploring something, and we see that there's something happening, right? We can almost see the conflict, although it's not maybe spoken about. We can say, so wait, check inside. Is there anything that does not like or does not agree or doesn't think it's a good idea what we are doing right now, right? Okay. Or do you think we should leave, if we are exploring the system, if we are using the meeting place, for instance, which is one way to explore, right? We can maybe say, do you think it's useful to leave anything else, any empty chairs, just in case for anything, right? So it's just different ways of maybe just including some aspects or parts that might not be showing up in the beginning, okay? Sometimes when we ask for a drawing, we can find where the missing pieces are. Sometimes we find patients that will draw like a huge blank space, right? Or sometimes they draw something, they cross it out, right? And they say something like, I don't know what's in there, right? Or there's a huge fog, or there's this darkness, and I can't see beyond that, right? So that's pointing out to things that are missing in the system. And of course, to really high phobia in there. Okay, one of my patients, she only was able to draw a young part, and then everything was a fog, and she did 3 lines, and underneath those lines, she said, many people are shouting. I can't understand anything, the phobia was too high, and that's an example of, with her, I had no idea about the system because she could not even do that in the beginning. Okay, so, and some patients, they are used to censoring voices or parts, especially if they had other therapies where the intervention was, don't pay attention, it's not real, just try to do something else, try to talk louder, put music on, and then, of course, the voice keeps screaming anyway, and even louder and nastier. So that doesn't really work. Okay, and all of this is through reaching agreements and developing cooperation and teamwork, okay? I put it in the last step, but I think we do it from the beginning. I mean, it's impossible to do therapy without trying to include this in the work, right? So general agreements initially that are tolerated. They don't have to be liked, but they could be tolerated or accepted as something that could help the whole system, right? And this is something that is going to, little by little, is going to start happening as we are doing all this modeling with the other steps that I was speaking about, right? Okay. So all of those previous steps that are really basic, right? For some of you, you're familiar with this work, they are geared towards promoting understanding and empathy between patient, parts, voices, right? And the idea is to increase understanding. When we increase understanding, it leads to greater compassion and empathy, which is something that we need to achieve any changes that are going to stick in the system, okay? And this in turn allows for cooperation. So, okay, I only got through 10 steps. Oh my God, this is horrible. Any questions about this part? What does that mean, Giovanni? I have to thank Giovanni because he actually did a really nice work helping me review all of this OCD structure head. Any questions about this? I know I just threw a lot of information. Do you want to ask anything? Comment anything? Yes? Okay. Okay. I'll try to repeat. I hear. Oh, the translators cannot. Okay. In the back.
Thank you a lot. But I have one question. You said about dividing the parts. When you ask each part, it can what they think or what they feel. You said it's a risk to divide more than to.
Okay, so the right word is to not integrate. Okay.
Yeah, I know.
So maybe I'm not using the right. Yes, I think that sometimes we become a little bit too obsessed. Like, let's say we know somebody has a 5-year-old,
Yes.
a baby part, a devil part, a shadow. I don't know, 10 parts.
Yes.
And we identify them,
Yeah.
and we are working with something, right? It's more integrative to check in a general way and say, so as I say this, check inside and see if it doesn't fit for anything inside.
Yes.
Right?
My-
Sometimes we go into, okay, check what the baby thinks, check what the 5-year-old. I don't think we need to do that, and I see that too often. And I don't think that's an integrative way of proceeding in many of the cases. Yeah?
Because I find sometimes I try to, if we work with something, and I have like a meeting in the meeting space, I have 5 pieces, 5 parts. Then I find it helpful to actually ask each part. But now I get a little afraid when you say I might.
Okay, so the meeting place is one way to explore.
Yes.
Right? And it should be for a specific purpose, right? What are we trying to achieve? If we are trying to get a meeting with the different parts, of course we're going to be asking each
Okay,
part.
thank you. Then I'm
because
fine.
That's a meeting. So
Yes.
we want to be curious, and it's, creating a space of curiosity, trying to understand what each one might need, etc. And there, we have a specific goal, which is checking with every single part that wants.
Yes.
That
Thank
wants.
you. I just had to clear it out, so
Okay.
I was
All right.
right.
All right, so it's in that, right?
Thank
What
you.
I'm talking in general in therapy. I think we do that too much, and I think this is not helping because parts are not people.
Yes.
We cannot treat them as people, and often what I see is that they are treated like people. Like a real 5-year-old is not a 5-year-old. It's a part of the person they cannot integrate, right? But it's not a real child, right?
Thanks.
Anything else? No? Should I continue? Are you doing okay with all this? I hope I can show a video of towards the end. You want to say something? Okay.
I love and very appreciate this idea of constant modeling. You are there to be a model, and I very much appreciate it, and I heard it also today. I want to underline it. It's really how to have the therapeutic attitude.
Okay. All right. Thank you. Good. Okay. So, all right. So just a couple of things about the adult self, right? This is just a concept. This is just an idea of that we can use to keep in mind how we want to be doing the work and when it's possible to do it like this, right? So one of the things that we try to encourage is try to get this part that we can be working through, right? To be curious and try to understand, and it represents an emergent set of cell capacities that are not developed in any specific part of the personality. It's based on the concept of the adult self concept is based on the future self developed by Korn and Leeds and the healthy adult scheme from schema therapy, right? This is a little bit the idea, and that initially in schema therapy everybody has at least some version of the healthy adult, right? And initially it can be the therapist that is functioning as this healthy adult that is modeling, okay? And the idea is that through treatment, patients can internalize the behavior of the therapist, right, with their own adult self, okay? And like I was saying before, most adult patients have some version of this healthy adult, right? It is going to be higher in higher functioning patients, right, than in lower functioning patients, but every single human being has this capacity. What illustrates this idea is this picture, this drawing, okay? So here we see a seed and then we see the tree. Initially, we don't see anything, but it's there. So this is the idea. Every single human being, even the most damaged human being, has the capacity to develop into a future integrated adult. Okay, it's not easy, but we need to really believe in this, right? And one of my colleagues, when I was explaining this with more time, Elan Shapiro from Israel, he was saying, I like this idea because if I understand it, sometimes we think, I hope this person can change. And hope, it doesn't really do it, right? So it's like, I believe this person can do this, right? It's a different way of being in front of really challenging situations, and I think that's helpful, right? Of course, we can find many complications, but it's possible. Okay, so yes, we want to be, one of the main goals is to show the patient how to communicate with all the different voices, different parts, right? And yes, I know, I mean, many of my good colleagues are here that do the work directly with parts. And I know if Suzette, I don't know if she's here, but she would say, well, sometimes, you know, you have to do it. If we can do it the other way, that's the most integrative way to proceed, right? So yes, we can find exceptions, but if we just can keep this adult self present most of the time, we are going to be avoiding a lot of the switching that might be taking place with many of the cases that I just, you know, we feel that, oh my God, what's going on right now? Okay, so yes, this is about modeling again, like I was saying, and what we want is, I mean, this is something that it's difficult to explain shortly, so I just want you to get the idea. And through the adult self is we keep the whole system in mind, we are always respectful, this is basic. We develop this healthy curiosity through modeling, validating all parts, being compassionate, helping them be compassionate, right? Promoting this dialogue, communication, and understanding. And this is the idea that it's about teamwork, right? How everything in me can have a function and it makes sense, okay? So yes, I think some of these things I covered, so I'm going to pass it. I'm going to skip a little bit. You have it in the handouts if you want to be more, many things we covered, so I really want to get to the part of exploring the system and reducing the conflict, okay? And one of the things I really like is this picture. I think sometimes pictures can really help us understand better than long explanations about something, right? And talking about what happens inside is not always easy. We need to be very patient, right? Not get frustrated and really keep in mind that sometimes there's too much noise, there's too much pain, there's too much conflict inside, and this is why they can't sometimes even look inside, okay? Too much phobia. And many of our patients live in a constant battle with themselves and their inner experience, they have no idea how to describe it, right? It is very challenging for them. There's a lot of shame around what's experienced also. So this is why I was introducing all these little pieces of big work in the end to work with this type of situation, right? So here we go into my other OCD piece of my brain, whatever it is, right? So if we want to be exploring the system of parts, again, yeah, OCD, but not fixated on something in a rigid way, okay? So this is a guide, just a guide. So we can keep in mind, okay, when I'm confused, what am I trying to explore? What can help me be more clear about what's really so confusing for this person? So we can go with the moment of onset. We can maybe try to get characteristics of the part. So how do you see this? This girl, she's hiding. She's hiding where? In a corner. Okay, what do you think? So we can get some idea, right? Identifying the message, how the interaction is, right? Now I see two parts fighting, so what's going on? Let's try to get an idea, okay? So some of this I covered already, and you have it here, and this is where I go to the second OCD, please. Okay. So once we start working with parts, and this is something that I learned through some of my patients, right, is that we need to pick up the work. We can't just explore in one session and the next session just go with whatever they bring in, right? Or maybe they are avoiding something because, you know, this is how it works, and we just go to something else, right? So we need to follow up. We need to be consistent again, right? So if we were working with a specific challenging part or frightened part or suspicious part or whatever in the previous session, right, just make sure that you have a structure to get a sense of what's working and what's not working in therapy, okay? So for instance, something that I like doing is always ask, how did you leave the session, right? So how did you feel? What happened after the session, right? And sometimes they can say something like, well, first I was upset, I was sad, or, I was confused, but then, I felt better or something. We can get a sense of what happened. Or we can get the typical response, I don't remember. What did we talk about? Right? So we do get relevant information with that, right? Or they can say, oh, I was fine. Yeah, I really like what we did. I mean, I ended up in the hospital, after drinking a lot and cutting myself. Yeah, but it was fine. And this is somebody that is not very good at pacing or identifying, right, what can help them. So this is something that can give us crucial information about where to continue, right? So, yes. How about the rest of you, right? How was in the part that was angry? How was it this week? Right, so we can get a general sense of maybe the results, right, the effects of the work, okay? How's everything inside this week, right? And if we gave any suggestion, right, let's say, for instance, in one of the videos the video I wanted to show, I suggested to one of my patients that has been in a constant battle with all her parts for many years, and this is after working with the system, I suggested that maybe she could actually watch a soccer game with a young part that also likes soccer, okay? And if we do that, make sure that we check. So how was it? Did you try it out? What happened, right? How did it feel? Because maybe another part doesn't like this, and then we get more information about how we can actually explain this or set it up better, okay? So yes, make sure that we explore that. Then if something happened during the week, right, or something happens during the session, we need to check, right? So maybe a patient will say something like, well, I was fine for 2 days, but then she just went crazy. And, and this happened, explore that. Okay, so just getting this kind of a structure, we can get a lot of information about how to proceed and continue the work. So it's not, we feel we know what we're working on, and it's not just, following the crisis of the week or whatever. Okay, and if something shows up during the session, so what just happened? Okay, so the part says I'm stupid, and that was after I said or did what, right? And then we just keep exploring, right? If we suggest something, what happens inside, as I point this out, okay? And maybe sometimes we get conflict between parts, and then we just need to be addressing that, okay? So this is in general, right, a general way. And then, like I say, beginning of session, we get a lot of relevant information about how the work is doing. And in the close of the session, we want to close with some time to kind of reinforce the work that we have done. Sometimes we can maybe validate, say, thank you and thank everything for allowing us to do this. I really appreciate that this part that was so angry actually allowed us to do this, right? Or maybe we can spend some time saying, okay, so what was important? What do you take home today, right? What's useful about what we just did or what we talked about today. So these are good ways of closing, which are meant to promote or enhance realization, okay? And another thing that is very important, and this is something I learned to do with some patients, is always anticipate potential obstacles and problems. So something that might happen often, sometimes we do a session and we do this wonderful piece of work with a young part, right? Getting permission from the rest of the parts, and the patient feels really good, and this is very new and it feels nice, right? And maybe a voice that is always insulting says something different, right? And then we have a motivated patient, somebody that says, oh, finally, maybe this can change. But then they leave our session, right? And what is the voice going to do? They're going to, at some point, repeat what they learned to do because it's not internalized yet. It's not automatic, right? So we just need to make sure that we anticipate that and say, okay, so this was wonderful. How do you feel today? I feel really good. This is great. You did a great piece of work, and so did this part, and the others that allowed us to do this, right? But now, if the voice shows up again, just remember it's still learning, right? This is very new. So if If it repeats some of the things it learned to do, this is because it still has to learn, just like you had to learn, and maybe we can use an example or something that took them some time to internalize and learn. Okay, then we have the specific work with challenging parts, but I can't go into that. I mean, it's basically based a lot on what I covered. I really want to show a short example. Is that okay? So now, if please, any videos, I'm going to show a short piece of work, right? And it cannot be recorded in any way. So I'm going to show first, I'm just going to show a little short example of me trying to explore one of the parts. Okay, just going over, you're not going to know these by heart, this is just a reminder. Okay, good for the translators?
Bien, entonces, ¿cuándo empiezas tú a sentir esa sensación familiar?
Pues desde el miércoles de ceniza que empieza todo.
Vale, bien. Entonces, el miércoles de ceniza representa alguna situación que tú has vivido.
This is very triggering. This is somebody I've been working with for a long time, okay? Well, I'm not going to do this in the first sessions. That's going into trauma too quick, okay? This is somebody that we already have a sense of this.
Pues cuando su hijo como pues que ha repetido más de que no valía para nada, así.
Vale. ¿Y ese día se repetía algo en tu cabeza que te decía eso? ¿Entendí bien o no? Ahora, en este año. Sí, vale. Entonces, exploramos un poco eso.
So I'm trying to get her, right? Let's try to explore this, let's try to be curious and understand what's getting triggered, right? And at the same time, the function.
¿Eres capaz de explorar eso un poquito conmigo, esas voces que aparecen a veces?
Yeah, she's not too excited about it, is it? Is she? So sometimes just with some resourcing, right, or grounding, she can do a little bit more. Oh, sorry for the...
¿Tienes los muñequitos para cogerlos?
No nos han olvidado.
Se te han olvidado.
This is like a squish ball that she uses sometimes to stay present, okay?
¿Quieres un cojín para cogerlo mientras? ¿Crees que te ayudaría o no? ¿O no? No te hace falta. ¿No? ¿Seguro? Pues lo cojo un momentito, ¿eh? ¿No? ¿Sí? Siempre es así. Vale. Bien, vamos a intentar entender el tema de esas voces. Intenta explicarme cuántas son. Mírame a mí, ¿sí? Está bien. Está bien. Vale.
Okay, so it takes her a long time, right, to calm down a bit, then eventually we can explore. I just want you to get a sense of how difficult it is, okay? And this is her. This is session 115, which I think it's not bad for how she came in. She was catatonic when before I met her, so you know what that means. And this is her when she's more able to try to be curious about psychoeducation and the work we have been doing, okay? So in the previous session is when I suggested that maybe she could watch a soccer game with one of the young parts, and how would that be? So I'm going to ask her and then explore how the system responded to that.
¿Y qué notaste tú en tu interior cuando pudisteis ver el partido juntas?
Pues como alivio de... Como normalmente tengo como una tensión así, incluso cuando estoy viendo el partido, no sé, una parte que suele ser la que se introduce ahí de...
Sí.
Watching a soccer game is something she enjoys, and that was very triggering because other parts got triggered when she felt good and did something pleasant. Okay?
Como de hacer una cosa que es como perder el tiempo, pues normalmente o sea, viendo un partido, pues lo tengo como más activado, así, o sea, no sé,
Que no me gusta, sí.
que no me pesó esa parte, que normalmente sé que...
Genial.
Y como más, me parece que ponía lo de liviana, pero como más así, más... Como un momento donde no me sentí como luchando internamente, así.
It was a moment, when I did not feel any internal struggle. One of the few moments in many years. Okay, and for some of you that know her from Venice, right? You can see the change, right? I see Paula going.
Bien, ¿y qué notaste? ¿Notaste si alguna otra parte se inquietó o estaba todo más...
So I check with the part, I check what I suggested, and I check what happened with the rest when she did that, right? Remember what I was trying to, we get information about how to proceed.
más tranquilo?
No, solo esta idea así como de perder el tiempo, pero no,
Esa idea de perder el tiempo, es aprendizaje y cada vez esperemos que tenga menos peso. ¿Sí? Porque eso no es perder el tiempo, eso es utilizar el tiempo en algo que te gusta, que te sienta bien y que le puede sentar bien a otras partes de ti también. ¿No? Muy bien.
And she started reading some psychoeducation, specific psychoeducation.
Estuviste leyendo la psicoeducación, ¿no?
el capítulo 3 me parece que...
Vale. Y entonces aquí pones la parte de la personalidad que afronta la vida diaria es evitativa. Otra, ¿sí? Y otras permanece estancada en recuerdos traumáticos. ¿Entiendes eso?
Lo de evitativa no sé a qué se...
So she's bringing in curiosity about some things that she would like to understand better. Do you notice how that's a huge change for somebody that has been avoiding looking inside or noticing anything for years?
¿Cómo se refiere?
La parte, cuando tú estás focalizada en seguir adelante con tu vida cotidiana, ¿sí? El objetivo es seguir adelante. Una manera de poder seguir adelante es no pensar en todo lo que pasó. ¿Sí? Evitar recuerdos, evitar disparadores,
Pero
evitar...
solo dice como positivo como negativo.
And she can interrupt me now, which is inside I'm going, yeah. She would never do that before.
Informativo, eso es un recurso. ¿Sabes? Es simplemente que tú puedas entender que esto tiene sentido, que aparece porque tiene una función y que hay momentos donde, a medida que uno está mejor, puede empezar a hacer frente a esas cosas que intenta evitar. ¿Sabes? Tú y yo hemos ido trabajando cosas. ¿Sabes? Que al principio de todo era impensable. ¿Te acuerdas? Sí, entonces, ¿a ti te suena esto de la tendencia a no querer pensar, evitar, pero que de repente eso te invade? ¿O te aparece algo, sí? Pues eso está relacionado con las partes que están más atascadas en esos recuerdos traumáticos. Sabes que tú y yo hablamos varias veces de que la niña a lo mejor no sabía que ella no estaba ahí, que no podían hacerle daño y que fuimos viendo poco a poco, ¿sí? Que ella pudiese también notar, ver fuera, compartir cosas contigo, para ir pudiendo ver que ya realmente que hay pruebas de que no está allí, sí, que salisteis. ¿Te acuerdas de esto? Y alguna vez hablamos de que posiblemente alguna de las otras partes también están atascadas, por eso siguen repitiendo cosas que fueron necesarias. ¿Quién te sonará más esto que hablamos alguna vez?
Sí.
¿Entiendes esto?
Sí, pero no me así como si fuera así como mucho conflicto, así de...
Claro, porque hay mucho miedo. Primero, el conflicto está directamente relacionado con el nivel de miedo. El conflicto está también relacionado con lo que algunas partes siguen repitiendo porque realmente aún no saben que ya no es necesario. ¿Sigues? ¿Sabes? Y como no sabe que ya no es necesario, repite lo que a ti hacía que evitase castigos. ¿Entiendes lo que te digo? ¿Sí? Entonces, eso es porque tú y yo estamos trabajando con que esas partes puedan entender.
For the ones of you that don't know her, right, you don't know the case, the fact that she's just standing, not pinching herself, not losing the capacity to stay present, looking at me, that's huge because she could not do that before, okay?
Que pueden ayudar de otra manera, que no es necesario, etc. ¿Sí? Entonces, ¿qué pasa? ¿Te acuerdas cuando estábamos haciendo explorando y yo te preguntaba si la niña veía a las otras partes o si la adolescente veía, ¿sí? Que estaba intentando ver? Está relacionado con esto.
Okay, so we go over a little bit everything we worked on. Through her questions, she brings specific questions, right? And here she's asking about this issue. There were moments, and Ellert was talking about this too, when some parts were not aware of others, and others, right, were aware of some parts, right? So I'm bringing everything we actually worked with, right? And she's able to just reflect on it with me, which would be impossible before. So I know we are running out of time, and I don't want to take anybody's time, especially Ellert's. So we have a couple of moments for maybe a minute for questions, or how many? I don't know if I calculated right. Do we have a minute or two for any questions or comments? 2 minutes, okay. No? Yeah?
Thank you very much, Dolores, for a very rich and very clear presentation.
Thank you.
Of course, I recognize a lot and I sympathize with basically everything you said. Thus, thank you for that.
Thank you.
I do have a question, though. And it's a simple question, and I was wondering if you have a simple answer. What do you do if what you perhaps would call the adult self is not present in the room? That would sort of prohibit talking to
Yes.
that one. What would you do, and what do you do in these situations?
Exactly, that's a very good question. So what I would try to do is still talk as if it was present in the room. It doesn't always bring that representation back, but we can still get some information. What I would try to avoid is try to use that opportunity to get more information, which is something that I have seen, right? I would try to just say, hey, normally we see each other here. Sometimes it's somebody, maybe a part that doesn't know me, right? Are you thinking of those situations, right? So it's somebody, do you remember me? I'm your therapist. This was a difficult week. I will bring something about what we are doing, right? And I will be talking as if it was present, right? Because somewhere in there, right, like we were talking about, there's not this complete division. I mean, they're there at some point, and that, yeah, sometimes they don't come back fully, but they're there at some point. I don't know if that makes sense.
What's up next then?
Okay. Okay.
Perhaps I'd better shut up here and invite people to listen to my talk,
Perfect.
where that part was miles away for 2 weeks.
All right.
Okay,
Perfect.
that created a difficult situation, as it sometimes does.
Okay, and this is what also Suzette says sometimes when possible we can do this, and sometimes
Yeah,
it's
right.
easier. Exactly. Yeah.
I would certainly sympathize with the idea that there's a whole person,
Yeah.
and that we work with that whole system, with what that whole person is.
Perfect.
And you represent that very strongly, and I do think that is very important.
Okay. Thank
Even
you.
if we sometimes do talk to parts because there's no other way.
Yeah. All
Okay.
right, perfect. So it's good. So we can, that's a good follow-up.
Thank you, Dolores.
Thank you. Thank you very much. Anything else? No? Okay, so thank you very much. Thank you.